Today we have a very eminent neurologist, Dr. Roop. He is famous. We have heard his name so many times. I just want to tell you one thing before I read the slide which Anuja has prepared on his CV, that I have found a convincing neurologist about the word end of life care. And it is so difficult to make them understand that there is something called end of life care, or there is something called a care which we should provide when people are dying or people are in the suffering at the end stage of the disease. So but he is a person who is basically profession by profession. He is a neurologist, but he has got so much of passion to improve the status of end of life care all over the country. And I have seen him almost everywhere wherever the discussion of end of life care is going on. So Dr. Roop, we are really fortunate that you are there with us, and definitely all the MDs, MD, this program is basically we have planned for the budding MD palliative care physicians, but all over the country people are joining, and you know, after within 2-3 slides you will find that more than 100 people are there on almost all Mondays for these lectures. Dr. Roop basically he is a neurologist in famous hospital, Hinduja Hospital. We have heard so many times, and I have also heard so many good things about Hinduja Hospital. He has done his MBBS from Government Medical College Nagpur, DM in Neurology from GMC and JJ Hospital Mumbai. Basically, he was a head of the department at Nair Hospital and TN Medical College from 1991 to 1994, and honorary associate professor in neurology at Grand Medical College at Sir JJ Hospital 1998 to 2012. He is basically, you must have heard about the Forum for Indian Neurology Education. I think it's a very big organization, and he is founder trustee of this organization, and this organization is disseminating knowledge on the various courses of neurology. And we are proud and we are very fortunate that today the one who is disseminating the knowledge of end of life care amongst neurologists, he is there with us for palliative care physician. He is also a steering committee of LECT and the interdisciplinary task force of intensivist, palliative care physician and neurologist for end of life care. As I told you that wherever the discussion is happening, even in ICMR or in critical care society or palliative care society, he is always there. And I have seen him, I have seen with my own eyes that he's so passionate about it, and I don't know how he manages delivering so many talks of end of life care all over the country. So Dr. Roop, with this introduction, I think I would like to request you to start your talk, and we are really fortunate to have you with us. And thank you very much for everybody for joining this class. Yes, please. You can start on.
Thank you, madam, for inviting me. It's always a pleasure. And I'm going to speak to you about the approach to neurologic disease and palliative care. Basically, we have two talks. I have two talks. So the first talk is the basic neurologist approach to clinical management. Then we go on to the assessment of and management of neurologic weakness in two prominent conditions that are important for you as well: motor neuron disease and malignant spinal cord compression. Next week, we'll broaden our gaze, look at all conditions that need neurologic conditions and need palliative care. Palliative care in patients with stroke, palliative care in prolonged disorders of consciousness. Although they're very uncommon, they actually illustrate some very key principles. Right. Now, the neurologic method, you will have heard this perhaps even in your third MBBS. It's all history. So when I take a history of a patient, obviously now at this stage, it does tend to be a little, it may seem a little chaotic, but when we learn, we are taught that we have to do it absolutely systematically, start from the top and go on down. So you ask for a history of headache, seizures or loss of consciousness, changes in language, cognition, that's thinking, then visual symptoms, then bulbar symptoms like speech and swallowing, then motor problems. And the motor problems are not just weakness, but also difficulties in control, stiffness, slowness, sensory changes, and sphincters. And having done this, then we are in a position to um, make sense out of what we have, the information that we have received till then. Now, you go on to the examination after the history, uh, and we'll go through the points in the examination, because when you do this, the most important thing that you do first is to correlate the signs and the symptoms with your neuroanatomical knowledge. That is called localization. Because unless you know where you are, you really don't know what you're doing. And then the time course of onset of symptoms and so on will give you the possible pathologies at that localization, which allows you to generate a hypothesis about what the patient has. And then you do investigations to confirm that hypothesis. Now, as you get more and more experienced, you start using more and more of pattern recognition. So you may bypass all of this, but even now, there are times when, with a difficult case, you literally have to, well, from running around in the fifth gear, you have to switch down, go back to first gear, do all of this systematically, and then make sense out of what you're seeing. So, if you look at movement, for instance, the movement of any part of the body is controlled by the upper motor neuron, which starts off in the central nervous system, brain or the brainstem, then connects to a lower motor neuron where the effector is the muscle. Fairly simple. The upper motor neuron, and to some extent, a little bit of the lower motor neuron, is affected by inputs from the basal ganglia, the cerebellum, and sensation. And the lower motor neuron connects to the muscle at the neuromuscular junction. So this is the basic plan. So for instance, let's look at somebody who has developed left leg weakness. Okay. Now, if it is from the upper motor neuron, the upper motor neuron that controls the leg starts off in the brain. The axon runs down through the internal capsule, and in the medulla, it crosses across to the opposite side and controls this side. So from the right side of the brain to the left leg. And from there, it connects to the lower motor neuron, which is placed in the lumbar part of the spinal cord. And this lower motor neuron, after that relay, takes on the job of connecting the signals right down to the level of the muscle. And this lower motor neuron emerges from the spinal cord in the roots. Then it forms plexus and peripheral nerves, and finally the nerve, which is often a named nerve. And I'm sure all of you have had trouble figuring out which nerve supplies what and all that. Don't worry, we also run into the same problems even now. Eventually you get the muscle. Now, as far as the basal ganglia and the cerebellum are concerned, the basal ganglion, for instance, for this right-sided motor neuron, which eventually controls the left leg, it's the right-sided basal ganglia, which input directly across here. Whereas for the cerebellum, it is from the other side. So the cerebellum of the other side controls, the left cerebellum controls the right cerebrum, the brain. And because it is in this fashion, it's a double cross, the right cerebellum actually controls the, the left cerebellum controls the left leg. So left cerebellum, right brain, left leg. What about the sensory pathways? Okay, so let's look at two broad types of sensations. The first is spinothalamic. Spinothalamic refers to what we would call the cruder ones, but there's a part of it which is fine also. But this deals with pain and temperature. Now the information, say for instance, comes up from the left foot, and the cell body for this axon, if you remember, the cell body for the upper motor neuron is here, for the lower motor neuron is here. Now the cell body for spinothalamic sensation, for any kind of sensation, is placed just outside the spinal cord in what is termed the dorsal root ganglion. From here, this sensation is real. I mean, it has two axons. One is the distal one, and the other is the proximal one. The proximal axon relays inside the spinal cord, and this information then crosses to the opposite side. In the lower part of the spinal cord, the crossing can take 2-3 segments. In the upper part, it is almost instant. So this information crosses to the opposite side, and then it runs on the opposite side of the spinal cord and up into the brain to reach the right side of the sensory cortex. This is a little interesting and important, because sorry, let me just do, yeah, okay. As far as proprioception is concerned, our understanding of position, in this, the axon, the dorsal root ganglion, does not relay in the spinal cord. It in fact goes all the way up to the medulla on the same side, then it relays, and then it crosses across. So you can understand that when you have an injury in the spinal cord, if you have an injury on the right side of the spinal cord, anywhere above this level, spinothalamic will be lost on the opposite side. Whereas for proprioception, the loss, if it is on the right side, proprioception of the right lower limb will be lost, not of the left. Okay, so these are, I think, little winkles that were made to keep neurologists excited. But anyway, what about motor and sensory representation in the brain? Now, in the brain, the main controls are in the sensory and motor cortex. Now, this is the right side of the brain. I mean, you can try and orient yourself. You're looking at the lateral aspect of the brain. So this is obviously the right side, this is the front, and this is the back. And in front of the central sulcus is the precentral motor cortex. Behind it is the postcentral or the sensory cortex. I don't know if you remember the picture of the homunculus, of the representation of the whole body on the brain. And if you remember, the leg is pretty small and shrunken. It goes down into the middle between the two hemispheres and then is draped over here. And then the arm and the face are much larger, because obviously they are so much more sensitive that there is a much bigger representation of the arm and the face. So leg, arm, face, the face being the lowest. Now, from all of these areas, information flows down. Now, commands are flowing down, and they will flow down and get transferred across to the opposite side in the medulla, that's in the pyramids, and you have the pyramidal tracts. But simultaneously, information is also flowing up. This information is flowing up from the thalamus, which is a great sensory relay station. It all comes through the internal capsule, and somewhere around here, the basal ganglia also put in their input. So you can see this is the broad pattern of organization. So let's look at what happens when the nervous system is damaged. So if you have damage in the brain, this is obviously something that will affect the upper motor neuron, because as you remember, the upper motor neuron is here in the central nervous system. The lower motor neuron is down here in the spinal cord, motor. Okay, now this upper motor neuron, as it goes out, will control, as I said, the left lower limb. This output here gets inputs from the basal ganglia, the cerebellum, and from the sensory pathways. But this is the final common pathway for motor control. If you have a selective small lesion in the brain, in the cortex, you can get isolated involvement of the leg. This is because there is a fair amount of spread of control over the cerebral cortex. In contrast, as these fibers come down, they kind of funnel down into the internal capsule, and from there they go into the brainstem. As they funnel down, because the fibers are much closer together, a lesion that may in fact be smaller than the one here will cause a much bigger deficit. And that will be a contralateral hemiparesis. It will affect the face on the other side, which is an upper motor neuron facial weakness, and a hemiparesis all down. Because the sensory pathways and other pathways are also there, you may have involvement of all of those two at that level. What about spinal cord lesions? Well, a small lesion again in the spinal cord on the left side of the spinal cord can also produce a monoparesis. But typically, because the spinal cord is a small, a lesion, a small lesion can cause a fair amount of damage. So, although the patient may complain of only left lower limb weakness, a careful examination will show you that there are signs on the right side also. So, typically, although we can see a monoparesis with spinal cord lesions, we usually do see signs on the opposite side. So you can get monoparesis with lumbar spinal cord involvement. Similarly, if you get a lesion in the cervical spinal cord, then on the left side, you can get, say for instance, hemiparesis because of spinal cord involvement. Again, the important thing to note here is, as compared to the previous diagram, there is no facial involvement. So the brainstem is not involved, it is below the level of the spinal cord, and there are below the level of the proximal upper limbs. And it's always important to ask when you have this doubt. Like I ask the patient, do you have anything above the neck, any symptoms above the neck? And they say nothing. Then you know that you're probably dealing with a spinal cord pathology. Okay. Now, if this spinal cord problem affects the upper part of the cervical spinal cord, then you can get quadriparesis or quadriplegia. If it is lower down, and we'll deal with that a little further, it will produce a paraparesis. Now, this much, of course, should be very simple. You'll be a little surprised. There are orthopedic surgeons who will see a paraplegia and do an MRI of this area. So please remember that if somebody is weak in the legs, you have to be careful to look for pathology all the way up to here. You can't just look at the lumbar spinal cord. Anyway, what about lower motor neuron involvement? So far we were talking of upper motor neuron involvement from the brain down to the spinal cord. Now we come to the lower motor neuron in the lower motor neuron involvement, the second neuron that starts off. Generally, they start off in the brainstem also for cranial nerve control, but for our purposes, we are going to be looking mainly at the spinal cord. Now, these are the motor axons. The cell bodies are in the spinal cord, and these cell bodies, as I said earlier, become peripheral roots, plexus, nerves, and so on. And you can see the area of damage, if it is lower motor neuron, will vary in that fashion. Now, I should have pointed out a little earlier that when somebody gets an upper motor neuron pathology, typically both upper and lower motor neuron will cause weakness, but upper motor neuron is not associated with any wasting. It is instead associated with spasticity, stiffness, and other symptoms. When it is lower motor neuron, because the trophic impulse to the muscle is lost, there is, in addition, wasting as well. And there are interesting features like fasciculations, so on, that come up. When you examine these patients, if it is upper motor neuron, you will see exaggeration of reflexes. If it is lower motor neuron, you will see loss of reflexes. The plantar is not affected by the lower motor neuron because The plantar reflex is an abnormal sign that arises in the central nervous system. So it is an upper motor neuron finding. So motor axons can be involved in a generalized fashion. When they are involved in a generalized fashion, the person can become quadriplegic. And this is what we are going to be hearing about a little while later in the disease that is called motor neuron disease, because it affects these motor axons throughout in the spinal cord and even in the brainstem. This involvement can be pretty localized. Just catch a single root, and obviously the root on the left side of the spinal cord to produce left lower limb weakness, usually say just a little bit of a foot drop or so. The same foot drop can also be produced by a nerve a little distally. So, for instance, this might be the L5S1 root, and this might be the lateral popliteal nerve. Both of them will produce a foot drop. There are differences in the pattern of the sensory involvement and so on, but we won't get into that. And you can make that distinction clinically. Of course, the involvement of the motor axon may be distally, not in the spinal cord, distally, after the the axons have exited from the central nervous system, and it can be a diffuse pathology, and then we call it, it involves the peripheral nerves, and then we call it a polyneuropathy. So the person is weak in the limbs, and the process is the connecting nerves from the central nervous system to the periphery. Now, there is an interesting thing about peripheral neuropathy, and that is that as these axons go down, you can imagine that the longest axon is the one that starts off here and goes down right to the bottom. So peripheral neuropathy, and because axon disorders tend to be length dependent, so the longest one gets affected first and most, and thus it goes on progressing proximally. You will see that this peripheral neuropathy, the symptoms of that are most prominent distally and improve as you come centrally. What about sensory involvement? As I had said earlier, sensory involvement, because you need sensation to control your motor system, you can get sensory ataxia if there is loss of proprioception. Now, when we are standing and walking, we are taking inputs from our vision, we are taking inputs from the vestibular system bilaterally, but there's a huge amount of input that is coming from the rest of our body, which all three of them we are generally not aware of because they are getting integrated in such a exquisite fashion. But this proprioceptive input, if it deteriorates, it can produce ataxia. And this ataxia will obviously depend on where the lesion is. If it is in the right side of the brain, it can affect selectively the left side of the body. If it is in the spinal cord, and this may not necessarily be pressure on the spinal cord, it could even be something like a B12 deficiency, because that affects the proprioceptive control out of proportion. You will get sensory ataxia. So there is poor motor control, no weakness, poor motor control because the input is inadequate. And of course, if it is a process that involves only the sensory parts of the peripheral nerves, you will get it, as I said earlier, only distally and in the limbs. Now, one thing to remember is that this much is this part of the history and the examination has to do with localization. But you also have to decide about what the pathology is. And the pathology, we use the time course to give us that kind of information. If something is going on for years and years, it is likely to be a degenerative condition or maybe even a benign tumor. If it is months or weeks, then it is usually chronic inflammation, in our setting, often tuberculosis or a malignant tumor. And you can see that these two differentials often overlap. Sorry. Yeah. These two differentials often overlap. If it is shorter than that, weeks or days, then it is demyelination. That's an inflammatory process that catches the descending pathways in the brain and the spinal cord. Or acute inflammation can also do the same things. It can be even shorter than that, in days and hours, and that also is usually inflammation. But if it is instantaneous, I mean, somebody was normal and the next minute they are affected, then it is vascular. So it's only a clot or a hemorrhage or trauma that produces instantaneous symptoms. Um, now, Anuja, any questions so far? I mean, anything that anybody wants to ask? Because now I'm moving on to motor neuron disease, weakness patterns in motor neuron disease. Hello?
No question, sir.
Okay, fine. So let me move on to a little more detail on lower motor neuron disorders. Now, I spoke about motor neuron disease. Now, here the involvement is in the motor axon in the spinal cord. So, the wasting and weakness is generalized because the axons are also involved in the brainstem. Bulbar muscles, which means speech and swallowing, are also affected. Because this is finally a motor neuron problem, the upper motor neuron is also involved, and you will get the findings of upper and lower motor neuron involvement together, and that produces one of the classic symptoms, signs of motor neuron disease, that a muscle or a limb which is wasted, weak, also has brisk reflexes. You see this combination, and to me, it means motor neuron disease unless proved otherwise. It's steadily progressive. There is no sensory involvement. It's a pure motor neuron involvement. From the motor neuron, these axons can be affected in the peripheral nerve. Again, you will get distal wasting and weakness. And as I said, this is predominantly bulbar. It has to be predominantly distal. It has to be extremely severe for it to come proximally up to the level of the brainstem. There'll be, because it is both motor and sensory, usually you will get distal. So in the hands more than the arms, and in the feet more than in the legs, you will get sensory symptoms and signs. And there are lots of causes for that. We are not going to get into that. Now, the peripheral nerve connects to the muscle through what is called the neuromuscular junction. This is really microscopic. And here, there is basically a failure of information transfer from the axon to the muscle, because there is impairment of release of acetylcholine here. And because this is in some ways dependent on the amount of use that you make of it, this is fluctuating weakness. The muscles that are involved are not just in the limbs, they are also in the eyes and the face. In fact, those muscles, because they are used so fast and so rapidly, they fatigue much faster and earlier. So you'll get more weakness in the ocular muscles and the speech muscles, and it responds well to treatment. This is a treatable issue. Of course, you can also have disease in the muscle itself. And here you will have both weakness and a certain amount of wasting, which depends on the type of pathology. So inflammatory, that is polymyositis, has a different pathology. Muscular dystrophy, where the muscle degenerates, has a different kind of presentation and a different kind of distribution. And some of these are inherited and incurable, but some can be treated, especially the inflammatory ones. So coming on to motor neuron disease. So the classic features of motor neuron disease are muscle weakness and wasting. This is because the lower motor neuron is affected all the way here. Simultaneously, you also get fasciculations. As these motor neurons are dying, there is an excitation. It's basically an excitotoxicity that happens in motor neuron disease, and one part of it is the fasciculation. And of course, because the central nervous system is also involved, you get exaggerated reflexes and extensor plantars. But throughout this, there is no loss of sensation. There are four basic clinical types, though of course towards the end they all tend to run together, and it really depends on where the disease starts off initially and where it is maximal. So you can have somebody whose bulb, that means the brainstem, is predominantly affected, or somebody whose uh, upper motor in the brain is affected. So the bulb is affected at a level above that. We call it pseudobulbar palsy. I'll just explain you that. Or you can have somebody where the predominant involvement is the lower motor neuron alone, without involvement of the bulb or the so much involvement of the central nervous system. And the classic amyotrophic lateral sclerosis has everything. It has all flavors. So let's look at them in a little bit of detail. So bulbar palsy, here the beginning is with weakness and wasting and fasciculation of the lower facial muscles and muscles moving the palate, most conspicuous in the tongue. So typically the speech gets slurred and the tongue gets wasted. And that once you see that wasted tongue, you'll never forget it. In people where it is even above that level, then what happens is that these same muscles, instead of becoming wasted and weak, are weak, but rather than that, they have slowness and spasticity. So the jaw jerk can be exaggerated. And because the central nervous system, to some extent, our automatic emotions are controlled in the brainstem, these patients develop a feature known as emotional lability. They just cannot control laughter, crying, and sometimes these are inappropriate. So, and this also can be fairly distressing for the patient and the family. Yeah. Progressive muscular atrophy, as I said, is just weakness, wasting, fasciculation, no sensory loss, and again, often starts off in the small muscles of the hand. And amyotrophic lateral sclerosis is the full, everything together: weakness, spasticity, increased reflexes. It starts off in the legs and in the hands. In fact, at the starting, although it may have started in the legs, the symptoms may have started in the legs. When we see them, we see hand weakness and wasting very prominently. Throughout all this, there are two sets of muscles that in motor neuron disease are not affected right till the end. Sphincter control is not affected. And the other is eye movements are not affected. Eye movements do get affected right at the end, but typically we see eye movement loss only in people who are on invasive ventilation, which means they have survived well beyond the period that nature would have permitted them to. What MND does not have, it does not have sensory involvement, it does not have cerebellar involvement or autonomic involvement. And as I said, eye movement and sphincter control can be involved very well. Now, because MND has, as it begins, has multiple patterns of origin, there have been different clinical classifications, and about 5% of ALS is familial. So there is an inherited component, and here the classification to a large extent depends on the genetic pattern that is involved here. As far as we are concerned, definite ALS requires upper motor neuron and lower motor neuron signs together in at least 3 regions, preferably one above in the bulb and 2 in the spine. And if you get that, then this is definite ALS and really doesn't require any investigations to confirm. But there are obviously probable ALS, lab supported, possible, and familial, where you get you have a family history, but the patient has still not developed the features. These are classic pictures from a book of wasted and weak hands, wasted and weak tongue, wasted and weak neck muscles, so a dropped head syndrome. We treat this with a drug called riluzole. It actually just enhances survival. In trials, it has done that by a few months. Not really that effective. Another drug that is often used is edaverone, but again, it does not seem to work much. In very doubtful cases, sometimes if you don't know whether you're dealing with inflammation, then you may use immunoglobulins, but this is like used only when the diagnosis is not certain. And of course, you have to address the question of magic remedies in stem cell treatments. Stem cell therapy is a potential therapy for MND, but at this moment, what is practiced in India today is a scam, an outright scam. So please remember that. What about managing MND? Again, I'm focusing on the weakness issues. Some of you may have attended my lecture on palliative care in MND earlier. And I'm happy to share that presentation also if anybody needs it. But what we do recommend, what I'm going to speak about is how this impacts, the weakness impacts the management. Exercise is important for maintaining function. Range of motion is simple. The caregiver can do it. Some people do use weight training, and there's a little bit of controversy about whether overwork can cause weakness. But if you watch them carefully, some of my patients seem to use it fairly comfortably. There's one who's been using it for almost a year now, but under careful supervision. And aerobic exercise. That, of course, can be done at any stage and to any extent. Some of the problems that they have because, again, of motor involvement is spasticity, cramps, and fasciculation. Spasticity is usually not a big problem, but you can use baclofen for that. For cramps, about the only drug that works well is quinine, not very easy to get in India, but and difficult to use too. For fasciculations, you can just use simple phenytoin or carbamazepine. People who have the pseudobulbar effect, I told you about that, where they cannot control their emotions. Although you can use standard antidepressants, they do work to an extent. The most effective is this combination of dextromethorphan with quinidine, not available in India, and we have to import it, but we get it fairly frequently. One of the problems in MND, for me or for anyone dealing with them, is that as they progress, bulbar function starts to get impaired and you lose communication. Of course, and in India, the way it is where patients are not given the diagnosis and so on, you can have this tragedy where the patient is no longer able to express his wishes. But what we do is, because the family is usually aware of what they are saying, ask the patient and family to write down questions before consultation. And if they are tech savvy, then there are lots of augmentative and alternative communication devices that are now available and they can buy them. ALS does have pain. The pain is related to immobility. So pressure relief and simple paracetamol and pregabalin will work. The bigger issue for them is mobility, at least for the middle part of the illness. So for upper body weakness, they may need to learn how to use adaptive tools, and an occupational therapist is very helpful here. Lower body weakness will need braces, crutches, walkers, wheelchairs, and so on. And the dropped head syndrome, which I showed you a picture of, you can use a soft collar. For fatigue, again, I don't need to tell a palliative care physician how to handle fatigue, but there are drugs that are available. Now, as they progress, the bigger issues that come up are how do you manage nutrition and how do you manage respiration. And as you can see, there is an element of monitoring and decision making in the use of a PEG and the use of, say, for instance, non-invasive ventilation and invasive ventilation. As the bulbar function deteriorates, breathing also starts to get affected. And you have to discuss the percutaneous endoscopic gastrostomy well in advance, because if you delay to the point that respiratory function is getting compromised, this is a patient who can end up getting intubated during the procedure itself. And that is a tragedy that's very often neither the family nor the patient wants. Ideally, you put in the PEG in time and you delay the requirement for respiratory support. But eventually, they do require respiratory support. And this is obviously when palliative care will get involved. For me, I work very closely with Dr. Raja Iyer. So NIV starts off, she's a she's a pulmonologist. So we combine forces and NIV comes in at this time, discussions go on, and very often families and patients decide to use morphine and sedation to avoid the possibility of invasive ventilation. Invasive ventilation can be a tragedy if the family is not prepared for it, because you have a mute, completely paralyzed patient who can survive literally for years after uh, ventilation, a tracheostomy or ventilation has been put. And it can be terrible. Right. So let me go on to the spinal cord, last segment of my talk.
Sir, do you want to take questions on
Yeah. Because I think because the last is malignant spinal cord compression. That's a little different.
Before that, we can take questions on MND. So there
Yeah,
are
please.
questions. One is about the LMN versus UMN involvement. So in LMN involvement, what are the kind of reflexes that we would specifically get in MND, because it might be a mixed pattern?
Yeah, so that's a key feature in MND as compared to peripheral neuropathy, whether reflexes will be uniformly lost. In MND, so if you see wasting in peripheral neuropathy, together with the reflexes will also be gone. In MND, on contrast, because the little patchy wasting of loss of the motor axons, those motor axons that are still functioning are getting increased input from the upper motor neuron because they've lost control from there. There's damage there. So there is wasting, weakness, and brisk reflexes. In fact, if you see this combination, then it is MND unless proved otherwise.
Sir, next is there is a question that all patients having speech disorder at end of life, do they suffer from bulbar disorders in MND?
Yeah, typically it is a combination of both. So the speech involvement can be pseudobulbar, but it can also be bulbar, and towards the end it becomes a little tricky to find out. Of course, you will have patients who have pure pseudobulbar. I mean, but then functionally, uh, the effect is almost roughly the same. Now, if it is purely bulbar involvement, there is no pseudobulbar, then you may find these are the patients who have problems controlling the upper part of the palatopharyngeal area. So they end up regurgitating fluids from the nose. Whereas people who have pseudobulbar, which means problems of coordination from above, have problems separating fluid and the air pathway below. So they choke. Okay, so that's a subtle distinction that you can make, but effectively, when you are looking at a patient's disability and distress, they tend to overlap.
Sir, there are various therapies you mentioned available for MND, management of MND. So, what is the rationale for each therapy that you've mentioned?
Okay, so both riluzole and edaravone are anti-excitotoxic. They reduce glutamatergic activity. That's their only rationale. And at this moment, we have nothing better. And if you look at it, I mean, if you looked at the classification, the genetic classification, basically, of course, I'll maybe speak about this a little further. Remember that the nervous system, you have these axons, these neurons, which start off in the central nervous system, go down. Literally, the neurons that you were born with are the neurons that you will die with, because there is no replacement of these neurons. So all these neurons have very exquisite, you can call it junk clearing mechanisms. All of us, as we go down, this junk clearing begins to fail. Now, depending on what the flavor is of that junk, you get degeneration of the nerve system. If it is predominantly affecting very active, say for instance, motor neurons, then it is motor neuron disease. But essentially neurodegeneration, say for instance, Alzheimer's, Parkinson's, this is all the same pathogenesis.
Yes. So, sir, this this is related. Will this disease trajectory, will the disease trajectory change with or without treatment in case of MNDs?
The trajectory doesn't change. You may prolong it a bit. So Riluzole prolongs it in trials by about 3 to 5 months. That's it. It delays onset of NIV or respiratory support by about 3 to 5 months. That's what it showed in trials. Edavarone is, in my experience, the evidence for that is even less. But some patients do benefit, so we do try it out, and well, sometimes patients feel they are benefiting and they go on with it.
Do we do genetic screening for all the patients having MND?
So, for one thing, of course, these genetic tests are becoming more and more available, but 95%, 90 to 95% of MND is acquired. Meaning it is sporadic, not acquired, I would say sporadic. So we generally don't do genetic testing unless there's a very clear family history.
Ethical question.
I'll just explain that a little bit.
Okay.
Now, if you remember, I said that it's a degeneration of the upper and the lower motor neuron. Okay. Now, in some patients, this degeneration affects other parts of the motor neuron. So it affects the motor neurons, the neurons that control cognition. It affects the neurons that are in the basal ganglia. So you have this overlap between, these are overlapping, genetically linked neurologic disorders where you get a combination of dementia. We call this frontotemporal dementia, extrapyramidal disorders, and motor neuron disease. And you can have families where these seem to run together. So if in a patient with MND, you get, say, a history that a parent or somebody else was affected with dementia, then you know that, then is when you know that this is potentially a genetic disorder.
Yes, sir. Sir, there is an ethical question that if the disease trajectory doesn't change, is it not prolongation of the misery of patient?
Yes, but we don't make that choice, no?
Yes.
And you are, again, ideally, the patient should be making that choice, the family should be assisting, but you know how it is. So unless we have these discussions well in advance, and there are patients, in my experience, almost everybody will take Riluzole. Almost. One of the advantages in India is Riluzole is actually quite an expensive drug, but for whatever reason, Sun Pharma in India began to produce it and distribute it for free almost about 25 or 30 years ago. So since I have known, it's available for free. So that is Riluzole. So everybody takes Riluzole in India. People abroad get surprised by that. About PEG, for instance, there are patients who will say no. And about invasive ventilation, it literally happens only when, say, palliative care or a neurologist who understands all of this and is able to communicate is not involved. The patient ends up in an ICU and gets intubated. Right.
Sir, there are a lot of questions on ethics. I don't know if we have so much time to discuss, because if we
you will
start,
lose the next section.
it will be too long. And maybe we can take next topic first, and then if we have time,
Yeah, sure.
Further discuss on ethics.
Okay. I'll quickly run through the spinal cord. Now, all of you understand that the spinal cord begins in the lower part of the brainstem. As we grow through childhood, the spinal cord that we are born with is not long enough, so it recedes, and finally, by the time you are, as you full-grown adult, your spinal cord ends at L1. So any involvement, if it is any kind of disease, L1 and below, will by rule has to be lower motor neuron. So if it is upper motor neuron, it has to be above this level only. Now, just to tell you the distribution of pathways in the spinal cord, the corticospinal tract is placed laterally. We are still dealing with the left lower limb. So the left lower limb is controlled by the left lateral corticospinal tract, which has originated in the right side of the brain. Okay. Now this is information that is going down. What about information that is flowing in? When it comes to the posterior columns, which deal with position sense, this is still on the left. As I said, this goes up to the medulla and then it crosses over to the right side. What about pain and temperature sensation from the left leg? As I told you, this comes in to the spinal cord in about 2 or 3 segments. It crosses over to the opposite side. So pain and temperature from the left leg runs up in the right lateral spinothalamic tract. Sorry. But there are other tracts that are distributed loosely around them, the reticulospinal, the cerebellospinal, and so on. And together with that are similar tracts that control bladder, bowel, and sexual function. These are all distributed all across, and they tend to be clustered in the middle of the spinal cord. So it is only when the central part of the spinal cord is affected that bladder and bowel function get knocked off. It's important to understand that. Yeah. So how is the spinal cord affected? Well, the spinal cord is in the spinal column, and you have the vertebral body behind. The vertebral body in front, and the spine. That is what you feel externally at the back. Inside the spinal column, you have the dura, you have the cerebrospinal fluid, and then you have the spinal cord together with the exiting and the incoming fibers, which are the anterior and the posterior roots, which together form the spinal root, which emerges together. The dorsal root ganglion, which I told you about, is on the posterior root. And then you have the other parts of the spine here. It's important to understand this because that tells you how you look at spinal cord compression in malignancy. If you have a complete spinal cord lesion, everything is gone. Motor, sensory, bladder, bowel, everything. What happens if the spinal cord is affected only half? For our purposes, we are still on the left lower limb. The left lower limb will be paralyzed if there is a right-sided spinal cord lesion. If there is a right-sided spinal cord lesion, so you will get, if the right pyramidal tract is involved, you will get, sorry, we are now dealing with this too. So you have paralysis on the right side, but the right posterior column will also be affected, but it is the spinothalamic on the left side which will be lost. And because that has already crossed over, and the effect on the bladder is variable because, as I said, this is distributed across the middle and you can get it on. It will be preserved because at least some function is present on the other side. What about involvement of the posterior columns here? This typically, it can occur because there is pressure from the back, but if there is external pressure on the spinal cord, the most sensitive are these two, the lateral and the posterior columns, and they both tend to get affected simultaneously. But you can get selective involvement of posterior columns, for instance, in B12 deficiency. And here the bladder probably stays intact, but they have difficulty in control. What about anterolateral? Now, the classic book picture of anterolateral spinal cord involvement is due to thrombosis of the anterior spinal artery. And in this, you will get infarction of the spinal cord, the anterior 2/3 of the spinal cord at just one level. And this can be devastating because there is both pyramidal and spinothalamic are lost, but there is some amount of posterior column function which is preserved. Typically, because the bulk of the bladder and bowel is also involved, they will lose that function as well. Let's look at metastatic spinal cord compression quickly. I'll just take a few minutes over this. One of the problems with this is that it tends to be significantly delayed in diagnosis. In one study, and if you're interested, you can look at this guidance from NICE. People take about 2.5 to 3 months after the onset of back and nerve root pain before this is picked up. And the later it is picked up, the worse they do. And paraplegia significantly impairs quality of life and survival. So anybody who has a high risk of bone metastasis must be informed about spinal pain, about the possible development. And this is something that you may well be involved with. And that I quite understand is why palliative care physicians need to be aware of it, because you may be managing a patient with bony metastasis but without spinal cord involvement. And this is a patient whose quality of life will be impaired if you don't catch it early. So you suspect if there is pain in the middle or upper cervical spine, which is progressive, unremitting. Spinal pain, if the roots are pressed, will be aggravated by straining at stool or by coughing or sneezing. In addition, you may get localized spinal tenderness, and the nocturnal spinal pain will prevent sleep. So watch out for this. Now, because this usually starts off in the vertebral body anteriorly and then spreads back, this is, as you can understand, this is the bulk of the bone here, which has a huge vascular supply. So disease starts off here, and it has been used to make a radiological and clinical grade. It's called the ESCC scale, and you can see grade 0 only in the bone, up to grade 3 where the tumor has spread and pressed the spinal cord. And your management literally will depend on this. For management, we use what is called the NOMS framework. So the neurologic involvement is from the clinical examination and the MRI. The degree of spinal cord compression determines the urgency of therapy, selection for surgical decompression, and choice of radiation technique. Then obviously there's oncologic. So the crucial feature here is the radiosensitivity of the primary tumor, whether it is radiosensitive or radioresistant. But another important feature is mechanical, spine stability. If the vertebral body, if two vertebral bodies are damaged, then the patient can't stand, because they stand, the spine will just collapse. And obviously you will also include systemic life expectancy in this. Now, I will have to drop this and just run through this very quickly. Definitive management will include radiotherapy. You can use either conventional or stereotactic radiotherapy together with surgical decompression. Now, in the surgical decompression, you may use what is called separation surgery. So basically you debulk the tumor, and then you can potentially give stereotactic radiation. Why does that work? Because why is it important? Because radiation damages the spinal cord. So you have to protect the spinal cord. If, for instance, you can excise the tumor, you can use conventional radiotherapy. And another treatment, surgical treatment that has come up is vertebroplasty, where you can actually strengthen the vertebral bodies and go on with life. Supportive management includes steroids. Typically, steroids are used until definitive management starts off. And then obviously you have to include pain management, venous thromboembolism prophylaxis, and management of urinary retention and constipation. Prognosis, well, in terms of prognosis, neurologic prognosis, pre-treatment neurologic function is the best predictor of post-treatment neurologic function. A patient who is walking, when they come to you and are appropriately managed, are most likely to remain walking. Some patients who are caught in time may regain the ability to walk with treatment. In historical series, when the spinal cord is involved, you're generally looking at stage 4. So it's approximately 6 months, but it also depends on the type of tumor. So if you have something that is chemosensitive or radiosensitive, you will obviously get much better survival. Now, this is the end of my formal presentation. We'll take questions for all of this right now. I'm giving you my email ID here. So if anybody wants this presentation, in fact, the clinical, the book that I took pictures from, I hope they don't sue me for whatever. But I'm happy to share the PDF of that as well if anybody is interested. But for that, you have to write to me on my email ID. Thank you.
So there was a question on advanced care planning in MND. When do we begin advanced care planning? How do we disclose the news to patient, and when do we do it?
So as a neurologist, I mean, for me, I'll tell you what is the biggest issue. Typically, and you see this, I mean, in some ways, MND is the closest to malignancy that we get. Um, Typically, the first clinician has made the diagnosis and done this usual, don't tell her, don't tell her. And once that happens, then by the time the second opinion comes in, the wider family comes in, the story has completely gone out of control, and the whole business of don't tell him, don't tell her has begun. Ideally, if the first neurologist conveys the diagnosis sensitively, and that is the worldwide standard, that either the neurologist who makes the diagnosis gives it or passes the patient on to somebody who has expertise in doing that. And this is something that I now do routinely. And once that is done, then comes the question of the dialogue with the patient. And that dialogue, as part of advanced care planning, typically you are working them on the PEG and the NIV and respiratory front. So advanced care planning is literally built into those decisions. You don't really need to separate out advanced care planning, because by the time the patient reaches respiratory failure, most of the decisions are made.
So, Sid, that was about ACP, but about symptom management in MND. What is the role of anabolic steroids in symptom management?
Very little. Some people do use them, but I think the metabolic problems outweigh the benefits. Far, far outweigh the benefits.
Okay. And sir, how do we titrate baclofen if at all we want?
5 mg BD, go up at weekly intervals. You can go up to as much as 40 to 60 mg, but not all patients tolerate that. Up to about 30 milligrams per day, people take it fairly well.
Okay. Does it also cause any respiratory problems? Will it increase the respiratory problems?
I think by the time that they are reaching that level, they're already immobile. So I doubt if I would really focus on baclofen at that point. I would probably be withdrawing it by the time they reach that stage.
Yeah. Sir, there's a question on this is malignant spinal cord compression.
Mm-hmm.
Will surgical decompression improve quality of life?
Yes. So that is the point. Why do you think this topic was selected for you guys? Because you will have patients who will have bony metastasis, who will develop spinal cord compression because of malignancy involving the vertebral bodies. And if you intervene, you will impact quality of life. Obviously, systemic disease is going to affect survival, but think of somebody who can continue walking. So if you look at the NICE guidance, they recommend surgery even in patients who have survival of less than a year or even 6 months. They are recommending surgery because it's so important.
Yeah, I absolutely agree, sir. So these patients for malignant spinal cord compression, should we be using venous thromboembolism prophylaxis for all patients of malignant spinal?
Yeah, if you end up with somebody who is paraplegic, well, I think I would probably use it in the perioperative period or until mobilization and so on, because once say they have reached a stage of complete immobility, then I suppose passive physiotherapy, compression stockings, depending on what is possible and what can be used. I mean, at that stage, you're looking at survival of maybe 3 months or so.
So when we are looking at a longer survival, probably we should consider venous thromboembolism prophylaxis.
And immobility, depending on immobility and longer survival.
Sir, there is a question on multiple myeloma. So how is multiple myeloma involvement of spine different from secondaries in spine?
It really depends on the systemic survival, no? Compared for instance, to a radio-resistant tumor.
Mhm.
Multiple myeloma, you may be able to stabilize the spine, give radiation, and get additional period and quality of life.
Yeah. So the secondaries in spine, multiple myeloma being very radio sensitive, so we can consider
Yeah.
radiation.
So you would decompress if needed. You would stabilize the spine and go ahead with localized radiation for relief.
Yeah, and there is this last question on management of constipation depending on level of spinal cord compression. So,
No, that you use your standard techniques. All that you people are taught about constipation, there is no difference.
yeah. So I think, sir, we have covered most of the questions.
Thank you.
Except for cost of care in MND. So I think there was a question on cost of augmentative devices in MND.
Yeah. So okay. So I'll just quickly. That's a nice question. That I'll just. There is. Of course, the simple ones are iPad and so on. But there is software, eye tracking software that is available, which you can install on a standard laptop, which allows an individual to use Blink to pick out letters on a keyboard on the screen and actually type out words. So it allows people to communicate. It um, uh, uh, a patient that I was kind of involved in the support group, they were discussing it. It costs about 1.5 lakhs. It requires at least somebody to be tech savvy enough to help set it up, but it's possible.
Possible, but expensive for normal people. So
Yeah.
thank you so much, sir. I think we have covered most of the questions. I'm sorry for extending the talk by 10 minutes, but it was absolutely worth it. So
Thank you so much.
I believe we'll have some more good discussion coming up next week. Thank you for participating, for the participants. Thank you,
all.
ma'am. Thank you, Roop, sir. Looking forward for the next talk, sir.
Thank you so much.
Thank you, Dr. Roop.